my thoughts, I would be interested to know the exact location of the pain. So yes, leg pain, I mean, where exactly? Because I think that would help me think more clearly what exactly we are dealing with. But if we are just talking of leg pain, I mean, it can be anything from trauma. So maybe this person is having a fracture from trauma, or again, uh, not very likely given his age, but a pathologic fracture as well if there are any predisposing factors. But again, leg pain, I would think maybe this person is having cellulitis. So again, history will help clarify all these things. Or maybe the patient is having a deep vein thrombosis. So I think more details will help me clarify what exactly we are dealing with.
All right. So uh, the oh, let me admit someone here before I proceed. Okay. So he reports that the right leg pain started the day prior to attending the OPD when he was walking, and it's worse with ambulation, but it improves with rest. There is no trauma, there is no swelling. He denies fever, rash, change of limb color. He denies similar pain elsewhere. He denies numbness or weakness of the limb. That's a very short HPI.
Okay, this is interesting. I'm looking forward to finding out what exactly is happening with the patient. So, a 31 years old male presenting with an acute onset of right leg pain, which is worse when walking, improves with rest, but there is no history of trauma. So, the very same things I was talking about seems to have been ruled out. So, no history of trauma, which means we can rule out a fracture or any soft tissue injury as a result of trauma, but we can still remain with fracture from other causes, because a fracture can be from trauma, can be from anything else. And then no swelling. I mentioned cellulitis, I mentioned DVT. They both present with pain and swelling. And again, there is no change of limb color. So both of these can present with erythema. There is no fever, there is no rash, and no similar pain elsewhere, and no numbness or weakness. So again, a number of things I think which have been ruled out by this short but very clear history. So I've mentioned some of those, but then if I try and broaden my differentials at this point, we've already mentioned some vascular causes, including DVT, but then leg pain can be a result, especially leg pain, which happens with ambulation, or can be a result of peripheral artery disease. But the pain, peripheral artery disease is more of claudication, or they get cramps in the muscles. But then, of course, when you know the way patients report to symptoms may not be 100%. We cannot rely on the patient's wedding to exactly present what we suspect is going on. So peripheral artery disease, but then he's 31 years old, and of course peripheral artery disease. The presentation, or at least if you are talking about claudication, mostly it's bilateral, not one limb. So, but then yes, I mean, if we are talking of something vascular, those are the two possibilities. But then with infections, we've talked about cellulitis, and of course, there doesn't seem to be any features of infection here. We've already ruled out trauma. This patient doesn't have a history of trauma, but of course, I mean, a fracture or anything going on in the soft tissue is still a possibility. And then it's just pain in one limb, so I cannot think of any autoimmune diseases which can present with, and of course, it's pain in the limb. We have not been able to localize it. It's just the leg, or is the pain coming from a joint like the ankle joint or the knee joint, I think that would have been clearer. So yes, I mean, up to this point, it's not exactly. I think it's not been easy to clench a particular diagnosis as explaining this patient's presentation. So maybe more details will help me make some progress.
Sure thing. So, the view of other system was unremarkable. Past medical history, this guy had a pulmonary embolism 3 years ago. And the doctors that attended him at that time thought was due to COVID vaccine because he received COVID vaccine and like after a week or two, he had chest pain, difficulty breathing, diagnosed with PE, was treated and it resolved. Family and social history. He is an engineer. He was born and raised in Kilimanjaro until recently when he moved to Dar for job. His parents and siblings are alive and healthy. He's a social drinker. He doesn't smoke and doesn't use any other illicit drugs. He is not on any meds, by the way.
Okay, so can I see the past medical history? Okay, so history of pulmonary embolism 3 years ago. And yes, this patient is presenting with right leg pain, and of course, it's of 1 day duration. That's the thing. So, of course, I cannot completely throw out deep vein thrombosis because, yes, deep vein thrombosis or venous thromboembolism in general, if someone has a past history of venous thromboembolism, that increases the risk of another venous thromboembolism event. So, and the presentation is for 1 day. I mean, yes, we do not see any pain. I mean, we do not see any swelling or any changes in color, but then there is pain. Of course, it could be an early presentation of deep vein thrombosis. So, given this past medical history, I think I can consider that possibility that we're probably dealing with the DVT. And then I mentioned some other differentials like peripheral artery disease, but then this patient doesn't have any history that is consistent with that. We do not see any diabetes here. The patient is not a smoker. We are not sure if there are any other metabolic risk factors like the patient is obese or but then we do not see a history of hypertension again, no other chronic illnesses. So I think some of the differentials that I mentioned become far-fetched. So let me see the family social history. Okay, so the patient is a social drinker, no issue of smoking. Yes, so I with this history, I think I have a few possibilities in mind up to this point in time. But then I think physical examination as well as investigations will help make some progress.
Okay. So, yeah. So we move on. And here's the general exam. He was alert and oriented when I saw him. He was a February, not pale, not jaundiced. He had bilateral inguinal lymphadenopathy, which we have seeing on each side, firm but non-tender. The lower limb exam, the left lower limb was completely normal, but the right lower limb had no edema, no rash. It was warmer compared to the left. It was tender. The tenderness was more on the gastrocnemius region, and the dorsalis pedis and posterior tibial pulses were palpable and intact. Systemic exam was unremarkable.
Yeah, so the patient has a bilateral inguinal lymphadenopathy, and these lymph nodes are non-tender. That's what is interesting. They are single firm and non-tender. So if someone has, of course, I mean, lymphadenopathy can happen with anything, but let's say if someone if someone trips, hits their toe, and you have some sort of injury, they can present with lymphadenopathy. If someone has an infection in the lower limbs, they can present with lymphadenopathy. And of course, you can have lymphadenopathy from malignancies. So I think, and these lymph nodes are palpable bilaterally. So, but I think what is remarkable is that what's remarkable here is that there is tenderness. There is tenderness on the right lower limb. No edema, no rash, but then it is warmer and it is tender. So the heat and the pain, I mean the heat and the tenderness, so it's warmer and more tender. You can, oh, those are some of the cardinal manifestations of inflammation as we learned in pathology. You know, you talk of ruba, which is, yes. So there is ruba is redness, right?
Yeah.
Yes, the erythema, and then there is the heat. I'm not sure what's the word in we say color, and then there is functional lesser, which is loss of function, and then you have tenderness. What's the other one? So you have like 4 or 5 features of cardinal manifestations of inflammation. So we see 2 here. It's warmer and it's tender. So I mean that, and again, I believe if anyone has attended a patient with cellulitis or a patient with deep vein thrombosis, you will realize that it's not very easy to distinguish those two. It's not easy to distinguish cellulitis and deep vein thrombosis. And sometimes all you do is so you do some tests and then you treat what is more likely, but then with watchful waiting, because it's not 100% certain that you are dealing with just this one thing and not the other. So I think with these 2 features, although there is no color change that has been reported here, but I think those will be top on my list of differentials. So deep vein thrombosis, especially with the reports of a past history of pulmonary embolism. So this is a patient with a previous history of venous thromboembolism, and then that point of tenderness is very concerning for me about the possibility that we are dealing with the DVT. But I will not completely throw out cellulitis, although there are no color changes that are reported. So I mean, the palpable peripheral pulses, they expected to be there unless if we are dealing with something arterial in nature. Let's say I mentioned the possibility of peripheral arterial disease. So they are palpable. I mean, even in peripheral arterial disease, they can be palpable but weaker compared to other peripheral pulses. But this doesn't sound like anything arterial. So if we are talking about something vascular, it's venous, and because there is no massive swelling, we would expect to have these pulses. So I think with this exam, those 2 that I mentioned are high on my list of differentials. Now I'm trying to think if I have overlooked anything else, but then I believe the exam would report if this patient had a wound or an ulcer on the lower limb that could explain the lymphadenopathy. I believe that would have been picked in the exam. So those are my possibilities for now.
Those are pretty good possibilities. So we move on, and here are the labs. This guy had a white count of 8 with normal differentials. His HB was 18.9. Upper limit of normal of that our machine was 16, so raised. Hematocrit was 59.2, also raised, and the RBC was 6.4, also raised. Platelet was normal, 185. Creatinine BUN were normal. Liver functions were normal. his urine was normal, RBG was normal 5.4. We sent the peripheral smear, and the result was that the RBC were normocytic, normochromic, the RBC were normal in number and how they looked like. The platelets were also adequate, like a normal peripheral smear.
Okay, so let me take some time to discuss this CBC here. So what's striking for me is the hemoglobin. A hemoglobin of 18 is elevated, and whenever you see this, so the first thing would be to ask yourself if we are dealing with true polycythemia, or if it's just a mimic, or for example, I mean, you can have a picture that makes you think that we are probably dealing with polycythemia, but it's not exact polycythemia. So a hemoglobin of 18 point, that is already concerning. So, but then, I mean, sometimes what I've learned is maybe I cannot just on day one say we are probably dealing with polycythemia. Of course, you go on and investigate the patient further, but sometimes it's helpful to do a repeat CBC, and then you do a repeat CBC and you find out it's normal. I do not know what exactly happens, but that has been my experience sometimes. But then, so when you have a persistently elevated hemoglobin count, so that raises suspicion for polycythemia. Now, when you are thinking of polycythemia, the questions are: is it physiologic or is it pathologic? And so, physiologic polycythemia, you can see that in people who are living in high altitudes. So, of course, I wouldn't think that all people who are coming from Kilimanjaro and other highland areas will present with a hemoglobin of 18. So I will not implicate that on this gentleman. But yes, I mean, physiology, for example, high altitude, and then people with, for example, congenital heart diseases can present with polycythemia. Smokers do present with polycythemia. This patient is not a smoker, and so if it's not physiologic, or is not due to something, any of the things that I mentioned, you can also have polycythemia now, which is not physiologic, not exactly physiologic. So, for example, polycythemia vera, which is a myeloproliferative disorder. But so with polycythemia vera, common findings. These patients tend to have can have hepatosplenomegaly. Of course, it's one of the important findings in order to make a diagnosis of polycythemia vera. So the systemic exam of this patient was normal. On abdominal examination, we are not told if this patient had any hepatomegaly or splenomegaly. Yeah, and can this hemoglobin explain? Can this hemoglobin explain what we are thinking of? The venous thromboembolism being one of those differentials. It can. So patients with polycythemia, the presentation is you have a number of things, but one of them is because of increased viscosity of the blood, they can present with thromboembolism in a number of vascular beds. But then, so this could be polycythemia, but then whether it explains this patient's presentation, that is yet to be established. So that is what I gather from this CBC. And then the peripheral smear was normal. I'm not sure if in a patient with polycythemia, if they have a cutoff to say this is abnormal, in that we have much more RBCs than we expect to see in a normal peripheral SME. I'm not sure about that, but at least the platelet count and other findings were reported to be normal, and we did not see any other abnormalities that would suggest that maybe we are dealing with any atypical cells in the peripheral blood, but that has not been reported. So I'm thinking it's probably just polycythemia. But again, with the patient's presentation, I'm not thinking it's polycythemia vera, although it could be. Any other thing that you have?
Sure. So another thing is that we did a Doppler as you suggest, and yes, it was keeping in a DVT as you were saying correctly, and this case is more about some of my questions to you. Like, so one of them would be, if you saw this patient 3 years ago when he had the PE, is there a thing that would have been done differently? And maybe another, if you're thinking of polycythemia vera, which you also say this patient coming from Kilimanjaro might be having just secondary elevated RBCs and HB and hematocrit. Is there more history from the patient that you can have? And if you want now to know, is this just from secondary or primary polycythemia? Is there any lab that you're sending?
Okay, so first of all, if I encounter a 31 years old patient with pulmonary embolism, I of course I do not tend to relax if I meet such a patient. I tend to investigate these patients, but then we are limited in terms of what we can do in investigating these patients. So I think, and another thing is, this is just my observation that around the time of COVID, of course, I mean, that could be a possibility because a lot of thromboembolism, a lot of thromboembolic events, I think, were reported around the time of COVID, from the COVID itself and from COVID vaccines. I think you remember we presented a journal on VITT. You remember that?
Yeah.
Yeah. So I mean, COVID vaccines, some of the COVID vaccines, I think that was including Johnson and Johnson, were had been shown to lead to a syndrome which was much more like the kind of thrombocytopenic thrombotic events that are caused by heparin. What do we call that? Heat, right?
Yeah.
Heparin induced thrombocytopenia. Yeah. So I think around the time of COVID, a lot of thromboembolic events were implicated either on COVID itself or the vaccine. So I think that was something quick to grab. But then you see venous thromboembolism in a 31 years old patient with no apparent risk factors. The patient is not known to have any malignancies. The patient is not immobilized. And any other of the traditional risk factors for venous thromboembolism that I think those are candidates that if I was in a setting where I could do extensive investigations, I would investigate them for, including for inherited as well as acquired thrombophilias like protein C, protein S deficiencies, factor V Leiden mutations, antiphospholipid syndrome, especially for a patient like this one. He has a history of pulmonary embolism. Now he has a history. Now he has a presentation that is in keeping with DVT. I'll be very much interested to make sure that I rule out at least some of the things that I've mentioned. So a deficiency of anticoagulants like protein C, protein S, factor V Leiden mutation, but then acquired thrombophilias, including antiphospholipid syndrome, although this patient, of course, we haven't had anything in the history that is suggestive of this. But then another thing that is striking is we find polycythemia in this patient, and the patient has had at least this is the second thromboembolic event. So we are thinking, is this a result of this increased RBC mass? That's a possibility. So I think what turns off my consideration of polycythemia vera is the absence of hepatosplenomegaly, but then physical examination is not perfect. So if you want to rule out polycythemia vera exactly, the lab test that you need to order is JAK. It's a JAK mutation, so that is what you order in order to see if polycythemia vera is present or not. So I think those are some of the things that I am considering. So I would order bleeding indices in this patient in order to see if there is any tendency toward hypercoagulability. But then with some of the tests that I mentioned, although I believe they are a bit expensive and not readily available, but I think because he's presenting the second time with a venous thromboembolic event, I think we have to investigate this patient further, including the tests that I mentioned.
Mm-hmm. Yeah, that's very nice. So I will tell you that so 3 years back when he had the PE, he had the polycythemia, and the doctor there saw it, but it wasn't in Kilimanjaro, and they told him that it's normal for this around here. We see it a lot because we work around here. So it was dismissed as the COVID because he had vaccine within like 2 weeks, and it was kept on anticoagulant for 6 months, and then they were stopped. So the question would be, would you give this patient a limited anticoagulant, or would have been for like prolonged for life anticoagulant? Because now here he is, another thromboembolism. And again, if before going to the labs, is there like a specific history of how people with polycythemia vera present, and yeah, that you can remember, apart from
Uh,
the hepatosplenomegaly, by the way.
so the presentation of polycythemia vera.
Yeah, like anything in history that it can raise our suspicion.
Well, so for polycythemia vera, the especially the symptoms are not very specific. So these patients tend to present with headaches. They can present with headaches. Um, they can also present with some neurological findings. And another thing is there is also an increased among these patients. They present with features of dyspeptic symptoms, or almost like peptic ulcer disease. They present, they report a history like that one. So headaches, uh, epigastric pain in keeping with peptic ulcer disease. I do not know the exact explanation. And then they can present with some neurological findings, especially in the extremities. I do not know, is it because of the increased RBC mass or what exactly explains those? And then physical findings, of course, it's the issue of hepatosplenomegaly. So they are clinical. In terms of symptoms, they are not symptoms that are very specific for this particular disease. Yeah.
No, fair enough. Would you give 3 months anticoagulant or prolonged if it was
Well, so
the
I mean, like I said, I think this is my personal bias. Whenever I encounter a young patient with venous thromboembolism, I wouldn't. I think I wouldn't treat them like simply and saying maybe it's because of this COVID. So if you say because of the COVID vaccine, that means it's provoked. And
Mhm.
therefore, if it's provoked, then you treat it for a short time and then assume that because the provocative event is no longer here, then this patient is safe to go without anticoagulation for the rest of his life. But then, so for this particular patient, I think I'll try and chase this polycythemia more. And as we are keeping, as we are investigating the patient, I think I would keep this patient on anticoagulation for more than that. And because it's not a thing that we can, of course, I mean, apart from the from the management of polycythemia, I think I would keep this patient on anticoagulation longer while looking exactly what is happening. So I think I would intend to keep this patient on longer term anticoagulation and not just 3 or 6 months.
You know, yeah, fair enough. That's very nice. So when I saw the full picture back, I asked this patient whether what happens when he shower with hot water, and he told me that he never showers with warm water because it gives him sting and burning sensation all over the body. So he has stopped. Does this make sense to you?
Yes, so yeah, that's another thing. The neurological symptoms I was talking about. I think it's yeah. I remember reading about a thing like this that patients with polycythemia vera when they tend to have they have to they tend to have a presentation like this one when they take showers with warm water. I remember reading about something like this one.
No, very good. So your diagnosis is polycythemia vera, right?
Yeah, so I think I'll say that the DVT that we are thinking about is because of polycythemia, but then if I investigate and find out that because I told you, so I think hepatosplenomegaly, I would tend to think it's an important positive to make a diagnosis of polycythemia because it's a myeloproliferative disorder, and therefore there has to be some sort of enlargement of these organs. But then if we do JAK mutations and they are positive, I think that confirms the diagnosis of polycythemia vera. So I think it's polycythemia, but to say exactly polycythemia vera, I think I have some reservations, but of course it's very likely. So further investigations will help me
Yeah.
establish the diagnosis with certainty.
Hmm. Yeah.
Yeah.
Sure. I was in the same line as you, and I had the diagnosis like you that polycythemia vera with recurrent thromboembolism. That was a previous PE, and currently he's having DVT. So first of all, I was so intrigued with what the doctors did 3 years ago. That was a life and death situation. Someone who's a PE, very young, and then dismissing them as you. This is just normal, and here they are with a recurrent thromboembolism. They could have died. So the way someone should approach polycythemia is that you find the HB to be elevated. I think it's above 16.5 in males and above 16 in females, plus or minus the hematocrit also elevated. So first of all, as David says, can be secondary. And what are the things here? First of all is the volume status. If you're dehydrated, your HB can go a little bit higher. But again, there are other things that can cause that. We'll see them later. But if it is not about dehydration issues and that's this true polycythemia, the first thing to do is to check the erythropoietin. My lab didn't had erythropoietin, so I sent this patient to another lab and another hospital, and then they also didn't have erythropoietin. So we don't have erythropoietin as of now. And so if erythropoietin comes back low, because erythropoietin drives the HB. So you expect it to be high if it's secondary. Erythropoietin high, HB high. But if erythropoietin is low, it's meaning the HB, the RBCs are out of control. The erythropoietin cannot help, so decide to go low so that to control that, but it can't. So if they are out of control, that's a myeloproliferative process, which is polycythemia vera or other myeloproliferative disorders. But if the erythropoietin is high, then that is secondary. So the things that David was talking about here, including lung diseases, um, living in high altitude, what the doctors in Moshi 3 years ago thought that this guy is living in high altitude, so it's okay to have this. But other things like obstructive sleep apnea and other things that are written here. So if we could have sent the apple, we would have been in a position to say exactly what it is. But so this patient right now, that the hospitals they went, they took blood, they sent to South Africa for JAK2 mutation. So that we are waiting for that. That also now I think is managed as a polycythemia vera. So a little bit of running point on P vera. So this is a chronoproliferation of erythroid cells. The epidemiology is that the median age was diagnosed around 60 years of age, but 10% of patients, they can get the thing below 40, like this guy. The way they present very specific symptom is what the patient said. When they have a warm bath, they get itching, tickling, stinging, burning, and some of them has what is called erythromelalgia, which is burning hands or feet with erythema or cyanosis or pallor. Thromboembolism is a presentation. This guy had recurrent thromboembolism, and they can also have bleeding, like they can bleed in the GI or in the brain. And again, they can have transient visual disturbances and GI symptoms. The way you make a diagnosis, there are criteria here. Either you have three major criteria or two major plus one minor. The major criteria include an elevated HB or hematocrit, hypercellular marrow, so you do bone marrow aspirate and see if there's hypercellular marrow, or you can send a JAK2 mutation. So if all of them are positive, you diagnose it. If there is positive 2 plus a minor criteria, which is low erythropoietin, you also diagnose that. Treatment, every one of these patients should have a phlebotomy that they donate 1.5 to 2 units per week if they are males, or half per week if they are females, and they should be on aspirin. But if they are high risk, and high risk means either they are above 60 or they have thromboembolism, like this guy, twice, you keep them on hydroxyurea for cytoreduction, which is 500 BID, and you keep them on anticoagulant for life, right? But the prognosis, this polycythemia vera, because it's part of the myeloproliferative disorders, it can progress to others like myelofibrosis, MDS, or AML. I was also intrigued that if I saw this patient 3 years ago, what would have I done? So, to decide whether you're going to give your patient um, limited anticoagulants or for life, you have to ask yourself, is their DVT PE provoked or not provoked? So if it is provoked, if it is unprovoked, you give it for life. But if it is provoked, you ask yourself, is the provoking thing just transient or is it persistent? This is very important. So if it is transient, you give it for 3 months. And what are the transient provokers? A major surgery, a surgery that takes like more than 30 minutes. Imagine something like knee replacement surgery, prolonged hospitalization, cesarean section, a fracture of a long bone, pregnancy. These are provokers, but they are transient. 3 months of anticoagulant. But there are other persistent provokers. Although it is provoked, but they are persistent, they'll be there for life. In this patient, you give anticoagulant for life. And these include malignancy, obesity, autoimmune diseases, nephrotic syndrome, polycythemia vera, the topic of today. And how about the COVID vaccine? Was there a chance that that COVID vaccine that the guy had, of course he had the J&J, but is it Did it cause the PE, or was just maybe sometimes we get lazy and find something easy to explain things? So it's true that AstraZeneca and J&J were associated with extremely small risk of what was called thrombocythemia, thrombosis with thrombocytopenia, not just thrombosis. I asked this guy whether he had anything in his platelet. He's an engineer, he knows everything that we were talking about. And he said, no, it was just my HB was high, hematocrit was high, my platelets were normal. So it wasn't that what the doctors thought, it wasn't VITT. It was pure thrombosis from something else. It wasn't the COVID. And then, if even if it was, the risk of this thing is very small. Like the literature reports at 3.8 cases per million doses. Imagine. So if you diagnose this, also you'll be very careful whether you are wrong. And it tends to occur, as reported in the literature, in unusual sites. So people have these cerebral vascular sinus thrombosis and mesenteric thrombosis, less like a PE and DVT, but it can happen. And again, it present within 2 weeks of vaccination. This guy had that. It is mostly reported in females under 60. So I think if I saw this patient 3 years ago, I wouldn't have thought that COVID vaccine caused it. It was just something else, and maybe even if he lived in high, I should investigate on polycythemia vera. So that's what the case of today. It shows a lot why we do what we do, like why you should be handy in making a diagnosis, and why you are doing what you're doing. Why do you give someone for life anticoagulant? It's not that it is written. The risk of recurrence in some diseases is very high. Yeah. So this patient right now, he's under care of some other doctors. I think they've kept him on anticoagulant, aspirin, and I didn't see whether they've kept him on the cytoreduction drugs. Yes, he donates blood, but I think they are waiting for the JAK2 mutation that will come. So, any reflection from you, David?
Thank you very much, Joseph. This is an interesting case, very interesting. So, leg pain, I think, interesting in all sorts of ways, starting with the clinical presentation. Leg pain, uh, and I think you did a very great job to diagnose this patient, because from what you are reporting, I think it would be very easy without a very obvious swelling, just tenderness and some warmth. It would have been very easy to miss the DVT. But then, so I think right from the diagnosis, and then coming to a full blood picture and suspecting something as the cause of the DVT from my full blood picture, I think that was a job very well done. So, and on my side, I think it's been an interesting learning experience. So I think we encounter these things many times, and I should say, maybe for anyone in the audience today, thinking that venous thromboembolism is a rare thing, or we only encounter it in old people, I think the narrative is changing. I think it's just a few months back, I I received a young patient, not even 30, I think he's around 28 by now. And the patient came with complaints of cough, and then he also reported difficulty in breathing. Now, what was more concerning, I think it would have been easy to say, okay, so we are probably dealing with a pneumonia, but this healthy 28 years old, why pneumonia? And then I started probing further and further, and he reported that he has been experiencing the difficulty in breathing actually gets worse with exertion, and later on it became pronounced even at rest. So I investigated the patient. A chest X-ray reported some pneumonic changes, but I thought we cannot go without a CTPA here, and the CTPA revealed a PE which was not even a small PE; it was actually a large PE. So I sent this patient to a hematologist, and my reasons for sending him there is because I wrote a whole list of investigations because I said he's only 28,
Mm-hmm.
and I took history actually for hours to see what exactly is going on, what exactly led to this pulmonary embolism. I couldn't see any risk factors, so I sent him with a list of investigations. A list of investigations. You should go do this and this and this. But yeah, I mean, I think what I noticed is okay. Maybe some of us are more afraid than others. So the hematologist did a good job. He kept the patient on anticoagulation, but he told him, okay, this is PE. I think we'll keep you on anticoagulation. Therefore, there is no need to investigate for these other things.
Mm-hmm.
Yeah, so the patient is under the care of someone else. Of course, he's on anticoagulation. The symptoms have improved, but then we cannot explain what exactly led to the pulmonary embolism in that patient. So yeah, I think it's a matter of awareness, and I believe maybe over time, as we encounter more and more cases, we I think will improve, and not just to treat a syndrome, but look for a causative, the exact or the root cause of that syndrome. It's like when you have heart failure and then you do not know the exact cause of this heart failure. Okay, you are treating the patient for heart failure, but it's heart failure secondary to what?
Sure.
Anemia secondary to what? So the same applies to pulmonary embolism. So I think for something like that, whenever we encounter those things, I think it's crucial to try and find as much as we can. Although I believe, as you might have read in the literature, that of course you can do an extensive workup and still not be able to find uh, what exactly led to that thromboembolic event, but that should not stop us from looking.
Mm-hmm.
So thank you very much for the case.
Yeah, thank you for discussing. Thank you, guys. So it was a very nice discussion. The way I was thinking is the way that you're thinking, and I love it that every Sunday we are here doing something like this, so that anyone else, maybe they see a patient with PEDVT, they know what to do, like put on prolonged anticoagulants and finding the cause. Like the patient you're saying, let's say maybe they have APLS, for example. We know it doesn't respond to the anticoagulant that is given to all the other PE. It's just it did warfarin. So interesting that it doesn't respond to the usual that you find other patients are put on the DOACs. So it's good to
Yeah.
investigate. Yeah. Do you have anything from the floor? Anyone with a question or contribution or the experience? Okay. I think none. So may I
Yeah,
wish you, yeah, David?
this audience is an interesting audience. Very good listeners. They enjoy listening.
It's okay. Yeah.
Yeah. So thank you everyone for joining. I hope we had something to learn today. So we actually did. You can see that the crowd is not a very huge one today. So many other weeks we do. I do just before the session or when the time for the session begins. I go and send reminders to the groups. So today I decided to do an experiment and see who remembers exactly to join without a reminder. And I see there is a number of Neds here who are very well self-driven, and they remember to set their timers and join in on time. That's very good.
Sure.
So it's good to see everyone here. Thank you very much for joining. Again, I believe people have interesting cases here, So we are still waiting for that day when someone will volunteer and share a case that they have seen, that they have attended, or at least observed other people attending that case. I think it will be a very good experience learning from you. So looking forward to that. So if there is nothing, it's been good to see you today. Have a good night and see you next weekend.
Good night.